Welcome dear students. While studying about the intracranial complications, in this video let us study about subdural abscess. Where is subdural abscess located? As the name itself suggests, it is the collection of pus between the dura mater and the arachnoid mater. It is below the dura, subdural. How does the infection spread into the subdural space from the middle ear? Again, same like extradural abscess, this also occurs by two routes. One is by the erosion of bone and the dura, and second is by thrombophlebitis. If it occurs by thrombophlebitis, the bone remains intact. Now, in the subdural space, the pus spreads very rapidly and it lies against the convex surfaces of the cerebral hemispheres. Now, what is the problem when it is in such close contact with the cerebral hemispheres and if it is spreading so rapidly? It can cause pressure symptoms. As the pus keeps on rising, the pressure symptoms keep on increasing. There is another possibility that the pus can get loculated at various places in the subdural space and they can form multiple subdural abscesses. So, this is the pathology of subdural abscess. The infection spreads via bone erosion or venous thrombophlebitis. Pus rapidly spreads in the subdural space and it causes pressure symptoms. And sometimes the pus can get loculated at various locations. Now let us look into the clinical features of subdural abscess. There are three factors that are responsible for all the signs and symptoms. Based on those three only, let us learn the clinical features. First among them is meningeal irritation. Now this abscess is in contact with both the dura mater as well as the arachnoid mater, so there is a lot of meningeal irritation. And whenever the meninges are irritated, what are the symptoms that you get? There is malaise, neck rigidity, positive Kernick's sign, increasing drowsiness, headache and fever. These are the typical clinical features of meningeal irritation that you find in any disease. So you will have headache, fever, neck rigidity, positive Kernick's sign, drowsiness and also malaise. This is one set of signs and symptoms. The second causative factor responsible for the clinical features is cortical venous thrombophlebitis. Cortical venous thrombophlebitis. The veins that are overlying the cerebral hemisphere, they undergo thrombophlebitis. And when they undergo thrombophlebitis, they lead to a variety of features such as hemiplegia can occur, hemianopia can occur. All these depending upon the location of the veins, it can occur. And sometimes even Jacksonian type of epilepsy can occur. You can see convulsions in the patient directly. And sometimes it can become so severe that it can even look like status epilepticus. The next group of signs and symptoms are because of raised intracranial tension. Now, while discussing the pathology, we have discussed that this rapidly increasing pus will lead to pressure symptoms. So, when there is raised intracranial tension, this can lead to various symptoms such as papilledema can occur. You can see that by ophthalmoscopy. Dilated pupils, ptosis, because of the third cranial nerve involvement, these eye features are seen. And even other cranial nerves can also get eventually involved, okay. For a diagnosis, we need to do a CT scan or an MRI. And how do we treat this? Intravenous antibiotics are prescribed to control the infection. After the infection gets controlled, we need to look for the causative factor, the ear disease, or if there is anything else, and then proceed with mastoidectomy. Now, what you have to remember is this is actually a neurological emergency. Sometimes the infection cannot get controlled with antibiotics, or the symptoms are very, very severe that you have to go for neurosurgery. A series of burr holes are created on the cranium, or a craniotomy is done, and then we drain out the subdural abscess. That is the main modality of treatment when the condition becomes serious and worse. And please remember, lumbar puncture is not done in these cases because it can cause herniation of the cerebellar tonsils. There is high pressure already and it is in an infective condition, so please avoid doing lumbar puncture. See, mastoidectomy is done only after a control of infection. So sometimes if the situation is serious, we will have to do a craniotomy and drain the abscess. And follow-up is required to look for any other intracranial complications. So this is about subdural abscess. This is also a very easy topic, just like your extradural abscess. I'll quickly summarize it for you. There is collection of pus between the dura mater and the arachnoid mater. And pathology is by bone erosion or by venous thrombophlebitis. If it is by venous thrombophlebitis, the overlying bone is intact. And the pus rapidly spreads in the subdural space and it causes pressure symptoms. And then it can also get loculated in various areas and lead to multiple subdural abscesses. What are the clinical features? Number one, because the meninges are irritated, it will lead to drowsiness, neck rigidity, positive Kernick's sign, fever and malaise. Number two, because of the increased pressure, intracranial pressure is raising, that can lead to various symptoms such as papilledema, dilated pupils and ptosis. And we also have symptoms because of cortical venous thrombophlebitis like aphasia, hemianopia, hemiplegia. All of them will occur depending upon the location of the subdural abscess. And sometimes it can even lead to epilepsy. These are the clinical features, and diagnosis is by CT or MRI, and treatment is intravenous antibiotics. After the infection is controlled, then look into the causative factor, and sometimes in a severe patient we might have to do craniotomy and drain out the subdural abscess and all the pus that is present in that area. Lumbar puncture is contraindicated. This is all about subdural abscess. Thank you very much.